fellow doctors. Today for the very first time we have Dr. Neelesh on our Eka for Doctors show. Dr. Neelesh is one of the most celebrated general physician and diabetologist in Noida. He has been part of World Health Organization and with Ministry of Health in Government of India at the highest policy level. He is currently one of the foremost voice who understands Ayushman Bharat digital mission and how it is going to shape the healthcare delivery in India and how it will impact doctors in general. He is a respected social worker and manages multiple health camps around the information and education of prioritizing health. Welcome to the show, Dr. Neelesh.
So this is the first time we have a doctor with us, and we want to bring this show to doctors in general so that they can have more information about doctors, understand, learn, and inspire themselves, and probably take a clue on how to even grow their clinical practice as a business and not just as a service. Right. So welcome to the show once again, Dr. Neelesh. And my first question for you is, what inspired you to become a doctor? हम बहुत सुनते हैं बाकी लोगों का, बट डॉक्टर के बारे में हम कभी नहीं समझ पाते हैं कि उनको क्या इंस्पायर करता है.
So if I go back to my school days when I was studying, and one thing was that there was a natural liking for, say, human biology and how the different systems work, how they interact with each other. So first thing was that there was an inherent curiosity about human biology. Second thing was that the people around me whom I used to interact with, they were mostly engineers. My father was an engineer. And the one person who stood out among them was his doctor friend, who used to cure them, even us, of all the diseases that we used to encounter at that point of time. And everybody used to give a lot of respect to him. So that thing remained in my subconscious mind that to have impact on the society as a whole, it is important that you are able to be in a position to help the mankind, and that position where you are easily able to kind of have that impact was a doctor's position. So that's how I think the two things joined up and I ended up being a doctor.
Great. So how was your journey in medical school and then from there to graduation? मतलब हमने सिर्फ मूवीज में देखा है शायद मुन्ना भाई एमबीबीएस. Is that the reality? How does it happen?
So it's not like that. So eventually, when you start your journey, it's a lot of hard work, and you end up studying for long hours. That is one harsh reality. And second thing is that you have to compete with a lot of like-minded individuals. So there is a very stiff competition. So if you look at the numbers, say for every one seat, there are at least not less than 10,000 to 50,000 candidates who want or who aspire to become a doctor. So it is that tough a competition. So you end up studying for a lot of hours, and you have to obviously sacrifice your other luxuries like going to parties, going to for other kind of entertainment. So that is one hard fact. Secondly, once you are into the college, there also the life is not easy. So you are exposed to, say, an actual corpse to begin with. That's not a very pleasant experience for a lot of young fellows who had till that point of time only thought about it, and they had never been exposed to a dead body in formalin and a very daunting smell, and you have to kind of do the dissection to learn, and that too a very different and a very tough subject like anatomy, from where we started our journey, and then from anatomy to, say, physiology and biochemistry, and then eventually jumping bandwagon to pathology, and then eventually graduating to medicine and surgery. So it's not that easy, I would say. And even when you have passed the initial hurdle, the next hurdles are a lot more difficult than the first hurdle. And we used to think like, chalo yaar, MBBS mein entry ho gayi to sab kuch ho jayega. So that is the easiest part, I would say. Life is more tougher after that. Once you graduate your MBBS, then you have to decide which branch you want to work with, and then eventually you have to appear for another exam. And once you do that, that is your broad specialty. You may again aspire to become a super specialist or a subspecialist. Then you have to again appear for another exam. That is another three-year schedule. So you end up studying not less than 12 to 15 years in a span of your youth, which for most of the people is like the best time. And we doctors spend that best time only in books and studying. So I would say it's a tough journey. It's not that easy.
So how did you decide on your specialization post your graduation, and what factors did you consider?
So while studying, a lot of things start coming to you naturally. Like few people, they are very hardwired about surgery, and a few people are more hardwired around like doing medicine or medicine subspecialties. So that is one aspect. Secondly, as I told you, there is a lot of competition, so the number of seats are limited. So at the end of the day, it is a trade-off between what you like and what you get. So you end up doing something which may or may not be to your best of the liking, but may also be kind of thing which you feel that it is the best at that point of time. And people, a lot of people do their own specialties, and they kind of then go on to excel in that. So it's, I would say it's a bit of both, like what you like and what eventually you kind of get in the entrance exam. So it's a trade-off.
Hmm. So how did World Health Organization and Ministry of Health happen?
Yes, so when I was choosing my broad specialty, so I ended up doing preventive and social medicine, which is again a subspecialty of medicine, but more oriented towards your health policy, health management, and how to manage big programs at scale, and maybe at the population health level. And with that background, there was a natural liking for working at, say, for those problems which have a big public health impact. So when I passed out, polio was one of those diseases which were quite rampant, and the government of India and the WHO were trying to eradicate that. So the first goal was to finish the disease off from the Indian subcontinent, and luckily I kind of applied for the position and I got that. And maybe around 4 or 5 years I worked very hard in the hinterland of Uttar Pradesh. So working at obviously at different positions, and we had a very big team, and we were helping the government of India to finish off polio. And in that journey, I have visited not less than 44, 45 districts of UP, and even to those areas where even road was not there. So that's the kind of journey I had with WHO. And after that, it was a natural kind of progression once you have worked at that level where so many lives are at stake and you kind of have an impact at that level. Then natural progression is to work at the higher policy level. That's how I graduated to then Ministry of Health, and I was kind of leading a National Technical Support Unit on Mother and Child Health, the NRU, and we were a 10-member team. I was heading that technical support unit for the Government of India, and obviously designing and monitoring programs for mother and child health.
So how did from there, how did you move towards operating your own clinic? You have been part of such esteemed organizations and have probably worked at levels where you could probably impact things at country level, right? And from there, how did you decide to move to?
So, very good question. So, what happened was that in the society where I was living, so what happened was that I was not practicing at that point of time, somewhere around 2015, 16, and one of the patients, he was down with fever, and it was a high grade fever, and somehow it was odd hours, and he couldn't get hold of a doctor, and he knocked at my door, and he asked for instant help. And so I was in two minds, that I don't practice and I work for the Ministry of Health, and how can I go out and be a clinician of that sort, and because maybe it's a different thing to do. But anyhow, the idea of helping somebody was more important than all these thoughts. So I eventually helped him out, and that was a day when he kind of felt gratitude about me being as a doctor, and he reciprocated that by telling more people, and then people started respecting me in a very, very different way prior to what I was being even as a doctor with the Ministry of Health. Somehow what I felt was that although you are doing things at a higher scale, at a higher level, maybe at the Ministry of Health level, but having a one-on-one connect with the population or community where you live and helping them out with their maybe daily issues is equally important. So it's not like that you are only working at a highest policy level, but you have a disconnect with the ground. So I don't think that's going to work. So eventually, I was a doctor, I'm a doctor, and I had to help people. So that's how the kind of switch, or maybe a parallel switch, began, and I started helping people out. And it eventually ended up me being my own clinic.
So that must have been a big transition, right? Moving in. So were you operating your clinic as well and then working for
Yes, so it
health
was a
organization?
bit hectic. So I used to work as a consultant with the ministry, and then in the night I used to come and used to have an hour's OPD at my own house. and steadily the clients started growing. And eventually I realized that it's a it's a tough choice, but even being a clinician is a good career choice.
So for you, it was one of the natural progressions that happened, right?
Yes.
But for many doctors, it may happen that they may choose: should I join a hospital, learn more, or should I start my own clinic? Hey, I have probably have enough experience working post graduation and all, right? So how do doctors decide these things? And they also tend to probably move in to their own home state, leaving big cities. How does that work for doctors?
So see, obviously, working in a hospital is very, very enriching in terms of experience. You get to see patients, and you get to work under senior consultants. So it's very enriching in terms of a young doctor gaining experience, learning things, getting exposed to the nuances of the hospital work. And I think it's very important thing to do in the initial years, and that's why a lot of people they do SR-ships. We call it senior residentship, and they even do kind of fellowships just to gain these more experiences. And once they have done that, then they kind of decide if they want to continue their career in a metro or shift back to their hometown. So again, this is something which is very, very individualistic. A lot of people they find solace in going back to their hometowns and working there, and obviously helping their communities. And then there are other people who feel that they need to kind of stay in the metro, because see what happens is that generally any new technology or any new kind of new interventions, they generally come in the metros. So a doctor who is staying there, so he obviously has got a natural advantage that he will come to get that exposure pretty early. So a lot of people they just believe that staying in a metro will give them that extra edge, and that's how they end up continuing their journeys in the metro. And obviously there's another factor is that tier 2 and 3 cities offer a lot of comfort in terms of commuting, in terms of ease of living, and also in terms of family support that they get. So I think it's a very, very individualistic choice, and the person who is in the shoes is the best person who can decide that.
So doctors are one of the most respected professions globally, right? But at the end of the day, they are also entrepreneurs in their own way, right? So what has been your journey around this, and how did you juggle around managing a business and treating people as well?
So see, you are right in one sense that doctors are entrepreneurs from day one. But doctors are entrepreneurs by not by choice, but by the circumstances. So if you look at the data, so they're not just enough jobs. There is not a single medical college where the campus placement happens. So you go to any engineering college, go to any business college, you will find them boasting around, we had 100% placement, we had 200% placement, we had such high salary packages. And just to give you a glimpse that the starting salaries for a doctor is even less than a simple graduate. That's the hard reality of life. So what happens is that once a doctor realizes that he has gained enough exposure, he has gained enough experience, and then he realizes another fact of the life that he is still not being paid, maybe commensurate to the experience that he has, commensurate to the fact that he has invested a lot of hours in gaining that kind of degree, or in gaining that stature where he is able to cure you. So then the hard kind of fact hits him, and he realizes that okay, now I will have to somehow decide what I can do. And so he starts his own entrepreneurship journey. And obviously, because these subjects are not taught in our medical college, we are not taught business, we are not taught finance, we are not taught even something as basic as how to open an account. So everything comes pretty naturally. Means you have to experiment, you have to fail, and then you have to learn. So there is no other way out. So a doctor is by kind of say by destiny, he has to be an entrepreneur or a startup founder. So his startup is his own clinic. Obviously, if he has good money, if there is family backing, some people directly venture out to open a hospital. Otherwise, they start with their small clinic. They go around building their own brand as themselves, like I am a good physician, and they try to excel in their work, because at the end of the day, being a doctor is a service industry. So you provide good service, quality services, and there are good health outcomes. So patient will be happy. And then the word of mouth publicity is good enough to create yourself as a brand. So few doctors are good at marketing themselves, few are not. But at the end of the day, they just go about providing good services at a decent cost, which is affordable to the maximum. And they first few years they just invest in building themselves as a brand. Once that happens, once they have reached that stage where they believe, so again it is some very individualistic. There are doctors who believe that they still need to invest more, and they first develop their practice. And then doctors who believe that, okay, now I've reached a stage here and now I should graduate to the next level. And once that feeling comes to them, then they start looking at other options like opening a hospital or maybe in partnership, and then getting to the next level.
So obviously all these informations are not available with doctors. It's not a handy information for them, right? So are there any associations, societies which help them understand, or how do they gather all these information? Because taking any step is a big step, right? Just after studies or any other experience, right? You don't know whether a patient is going to come to you or not. So how did you, so you explained your first patient, how did you get it? But what about other doctors? How do they happen?
So yes, I fully agree. So although there are associations working in the field, the respective branches with doctors who have graduated from those branches. But at the end of the day, they are not. Their objective is not to train doctors on around business or entrepreneurship. That's not at all their agenda. Their agenda is to advance the scientific thinking or the research in those fields. So obviously, doctors don't have that avenue. So that is again harsh reality. So again, coming to the same point, generally a lot of doctors learn it themselves. But to make the story short, the whole idea is about reaching the break-even point. So suppose first you have to evaluate what all resources do you have, how much you can invest, and within those resources you have to ideally first start with the clinic. So now when you have to start with the clinic, you need to identify a location which is easily accessible to the people. So there are three things which are very important when you start your journey as a clinician, and that too in your own clinic. So first thing is we call it as 3A. So availability, accessibility and affordability. So you should be available. So the more you are available to the population, the more easier it becomes them to believe in you. Second thing is accessibility. Are you accessible to them easily? Are you picking their phone calls? Are you helping them at odd hours? So this is another very important kind of behavior which at least the allied population wants, and they want that service at their own convenience. So accessibility is another important thing. Third thing is affordability. So you may like to charge more depending on your experience, but at the end of the day, your consumer, does he has that affordability? Does he has that purchase power to pay for your services? That is a very important consideration, and it also depends on the area in which you are practicing. So obviously, if you are practicing Mumbai or Delhi, so your kind of fee setting or that level of fee setting will be different from somebody who is operating out of, say, a tier 2 city like Lucknow or Indore. So that is something which you need to take into consideration. And secondly, the gamut of services that you are going to provide. So clinic in itself can provide at least all the primary care services. So you start with your own consultation, and then you keep on adding like medicines and lab and whatever other diagnostic services that you can think of relevant to your specialty. So if and when you decide that, again depending on the resources you have, that's the way naturally to progress into.
So it is a common understanding. Doctors never retire as long as they are working, right?
So I think it's both ways. So see, at the end of the day, it becomes a routine. So you get up in the morning, you do your daily course, and you go to the clinic and you interact with people. So interacting with people in itself is very fulfilling experience. You talk to so many people, they come to you with pain, and then when you alleviate their suffering, so it gives a very different kind of satisfaction. And there is, let me be very frank with you, there is no other thing in this world that can match that satisfaction. A person in pain and you are helping him out, and he kind of overcomes that, and that too with your help. So even if he is not paying you anything, but that feeling that you were able to help him out is something which gives you a lot of satisfaction. So that is the prime motivating factor which gives a doctor the fuel to kind of push along and push the boundaries. So that is one thing. Secondly, it's the other way around also. So once you have established yourself as a doctor, and the patients, they kind of also push you that we need your services. So why are you retiring? So you are able to kind of still see patients, at least give the consultation. We will not come to you for procedures, but at least give the consultation, give your opinion. So maybe a doctor may not be in a position to take the case, but at least give second or third opinion so that he gets the right direction. So I think it's both ways.
So these days we often hear work-life balance, right? But when I see doctors, they are probably working morning till late night shifts as well, attending patients. So how do you manage work-life balance, or is there any work-life balance for doctors?
So frankly speaking, it's a tough question to answer. Reason is that uh, again, first thing is it varies from individual to individual. Second thing, it varies from branch to branch. So there are certain branches which are kind of supportive branches, like you look at pathology and radiology. So they basically aid in diagnosis to the clinician. So obviously they don't have any emergency hours. So for them to decide, say, their work hours is a bit easier. And then there are patient-facing branches like broad specialties like gynecologists, pediatrics, general medicine, surgery, ENT. Even for that sake, your any other clinician branches. So in that case, when the patient is in pain, so doctors are ethically bound by their Hippocratic oath to help the patient. So for them, it becomes a bit difficult to say no even at odd hours to the patient. So there, even if they have a defined work hour, they still end up in a situation where the patient is banging their door and asking for their help. So I would say it's a bit difficult for them to be a very kind of say very clear that I will not work beyond this hour. So that is a bit difficult for them. But again, within this clinician branch also there are certain branches like dermatology, where again there are very few emergencies. So I would say one thing is your branch. Second thing is how you think about the whole thing. So once you have become a senior doctor, then obviously you have junior doctors in your team to take care of the patient. So then there is some kind of delegation of care to those, and then you can define your own hours. But obviously in the initial period of the career, work-life balance is a bit difficult to achieve. But I would suggest that once you achieve that level where you are comfortable, do start taking up time for your family and for yourself, because at the end of the day your health is also very important. And to be more clear on the perspective, doctors are the most unhealthy of the species on this earth. And you take any disease, diabetes, hypertension, any chronic disease, and incidence is highest in this doctor cohort. So yes.
And why is that, doctor? Because
So
you are supposed to keep everyone healthy. Why are you not healthy?
so again, coming back to the same point that you again raised, so long working hours, stress, and then patient care, everything takes a toll on doctor's life, and long sitting hours. So basically, a lot of doctors are not able to take out time for exercises and taking a balanced work life kind of situation. So I think that is taking a toll on them.
Uh, what has been the most challenging case so far? You would have probably met interesting people, interesting cases, but what has been challenging for you?
So see, being a diabetologist, one of the most challenging case was of a senior citizen female, and her sugar levels were fluctuating. And one fine day it was about 200 fasting, and another fine day it was less than 80. So it was kind of very wild fluctuations. And obviously, she was under treatment by some other physician, and she came to me for a second opinion. And I could find out what the best we could do for her, and she was adequately managed. And today she's okay. But the kind of worry that was on her face and on her kind of relatives' face and everybody who had come. So when everything went on smoothly and she was fine, so it was kind of a very satisfying experience.
So, Dr. Neelesh, how has practice for doctors changed over course of last 15 years? How you would have seen probably your seniors or doctors doing it, and how things are now with technologies coming in, right? Especially the gamut of patients finding about doctors much more before even visiting them, right? So, how are these things impacting?
So yes, obviously technology has changed the way doctors practice nowadays, and in fact, it has become very difficult to kind of ignore technology. Just give you some perspective. So before 2000, there was no mobile. So the only way doctor could reach to a patient could reach to a doctor was to reach to his clinic and take an appointment. Then came the mobile kind of convenience. So now they used to call the doctor. It was just very basic thing. And then came the smartphones. So now with the technology improving its kind of base, and doctors also following a little bit, things have changed a lot. So to give you some perspective, so health is considered as the last frontier to get digitized. So we look around us. So our say grocery person is taking money via UPI. A pan thela wala is taking money via UPI. So one thing is that everything has gone digital. Google has become ubiquitous. People search doctors on Google. They try to identify how much qualified he is, what is his experience, what are his credentials, what hospitals does he go to, what is his routine, at what time or what hours he is available. So they do a lot of homework on the doctor front. Secondly, they do a lot of homework on their own symptoms. They try to Google their symptoms. They try to understand what is ailing them. They try to understand what exactly can be the diagnosis or what is the probable diagnosis. Third thing, even when they have got the prescription, they've got the guidance from the doctor, they try to go and cross check if they have been given the right guidance or not, what doctor was saying, what doctor has written, and they can go and Google it. So I would say life has changed a lot. Initially, patient used to trust doctors, what they used to say. Now they judge doctors. They try to use technology as a resource to judge what doctor was saying, how the doctor has gone about it, how the doctor has behaved, how the doctor has diagnosed them, has he written them unnecessary tests or not. So a lot of judgment has come into play. So I think that has changed the whole paradigm between a doctor and patient.
So how do you think
These doctors, or have you stayed relevant with this change in technology?
By moving with that? So you have to move along with the technology. See, technology is an enabler. If you believe it is an enabler, it will help you out. If you believe it is a hindrance, you will always be stuck with it as a bottleneck. Try to understand. So when people around you have moved ahead and they are using technology, so it is but natural that they would also like doctor to also move ahead with the technology. And that's a natural expectation. So say, if I am using a Paytm, I would expect that my service provider or maybe my grocery person should accept their Paytm because it's convenient to me. Do you believe that or not? Obviously. So similarly, when the patient thinks that I am able to search him on the Google, why he is not available or his appointment is not available on Google? Why is that not happening? Why is doctor not moving ahead with the technology? Similarly, when I am able to order medicines online, so why is doctor not making that easy for me? So to give you more perspective, the biggest bottleneck in service, the perception around doctor service delivery is the prescription that he is giving. So a doctor writes a few medicines. Then there are 2 or 3 things which naturally a patient has to clarify. What is the name of the drug? How it has to be taken? And what are the nuances of how it has to be taken? So suppose I have written a drug, say to be taken before meal. Now how many minutes before meal? At what point of the day? Does it have got any relation with what I am eating? So suppose I have given an anti-diabetic drug, say 10 minutes before meals. So he would ask me, डॉक्टर साहब ये दूध के पहले ले लूंगा अच्छा कोई दिक्कत तो नहीं होगी, या मैं इसके पहले फल खा लूं तो कोई दिक्कत तो नहीं होगी? So there are a lot of questions around that. So one way the tech helps is that once a doctor gives a digital prescription, the handwriting issue goes away. The generic drugs, which is kind of ethically managed by NMC, that a doctor should prescribe generic names, it goes away because generic drugs are mentioned there. Instructions around how the drug has to be taken, that becomes very, very clear to the patient. And fourth, because the record is electronic, it can be seamlessly shared with the pharmacist or with any online service provider. So all these things make a patient's life easier. And obviously, when you do something which makes a patient's life easier, he is obviously going to value your service more vis-a-vis your competitor. So I think technology is an enabler, and not only about a digital prescription. Think out from the perspective what we talked before, availability. So if you are on Google, at least patient knows at what time you are available. You talked about work-life balance. If I want to have a work-life balance, it is important that my patient should know that I am not available after 8 p.m. How will he know? If I am not available on the Google or on any online platform, how will the patient know that I am not available after 8 p.m.? So it is important for me as for my work-life balance also. Third, affordability. So now I might want to be an affordable doctor, or I might want to be a doctor who is highly specialized, and I may be a bit costly, but because my service is good, I am confident, but there will be payers. How will the patient know? So if I am available online, I have given all my information around my experience, my degrees, my qualifications, and obviously around my fees. Then the patient who is coming and who is googling and who is taking note of my kind of credentials, and he is willing to pay, only that will come. So it helps me filter out the kind of patients who might be problematic for me if they come and they land up and then they realize that he's a costly doctor. So all these things are obviously makes patient's life easier, doctor's life easier. The only thing is that doctors need to realize that.
So you mentioned one point, healthcare is the last frontier for digitization, right? So what's happening in India about that, and how are we compared to global world?
So see, very, very pertinent question. So see, we are at least 25 years behind the West in terms of digitization of healthcare as a sector. I'm not talking about doctors alone, I'm talking about the healthcare as a sector. So when we call it a sector, what do we mean actually? So we mean that your service providers are not digitized. So it includes doctors, it includes hospitals, it includes labs. They are not digitized. Your service providers of other tangent like insurance industry is not digitized. Pharmaceutical industry is again not digitized. So what happens is that at the end of the day, when we compare ourselves to the West, we have a very, very big gap. And digitization cannot happen for the sake of digitization. There has to be some value for each and every stakeholder. A whole ecosystem, which was hitherto till this point of time, was not digitized. You want that to become digitized so that everybody gains some kind of efficiency or value out of that. So that cannot happen on an incremental measure. So it is not like today's pharmacists will go digital, tomorrow doctors will go, and third day lab will go. It's not going to happen that way in India. So what has happened is that Government of India has come up with a very transformative idea, very disruptive idea. This Ayushman Bharat digital mission. And why I call it as a disruptive is because what it envisages is that the whole ecosystem will get digitized in one go. So now, believe me, this has not happened anywhere in the world prior to this. You take one single country, this has not happened. Why it has not happened? Because it was not tried in this way. And what is so transformative about is the biggest kind of confusion in this whole digitization piece is around two things. One is who owns the data, and second thing is how can we ensure data privacy of the patient. So if you ask me, for any country, these are the two biggest problems to solve once you talk about digitization. And ABDM or Ayushman Bharat Digital Mission solve this as the building block. So they have tried to solve these two problems as a fundamental building block. First thing they say is the owner of the data is the patient. So neither the doctor nor the hospital nor the lab, nobody is the data owner. The owner of the data is the person of whom the data belongs to. It's the most fundamental, most transformative piece. Why? Because even in the West, this is not clear. Even in US, this isn't clear. There are hospitals who are sitting on these data points. They're sitting in silos. They don't talk to each other. You go to Massachusetts General Hospital, you will not talk to Stanford. And that will not talk to the Mayo College. But in India, what the government is saying, owner of the data is a patient. And second, the privacy is by design. So any and every stakeholder who wants to work in the health sector will have to go digital, and he has to ensure these two things. And third most important piece of information is that a data once generated cannot be deleted or edited. So say today I generate your prescription and you had fever today. So tomorrow I cannot go back in time and say he didn't have fever. And why this is important is again very fundamental, very, very important thing, because it will ensure fraud minimization for the insurance industry. What is the biggest problem for the insurance industry or in the health sector as a whole is trust. So patient doesn't trust doctor doesn't trust hospital doesn't trust insurance industry, and insurance industry doesn't trust the hospital because they believe that everybody is trying to take the pie out of it. They're trying to work or maximize their profits. But at the end of the day, nobody is thinking about the patient. And how the system should work, it should only work on the patient benefit or the patient, or you to say to maximize his health. But somehow we are not geared around that. And this ABDM is solving the puzzle in a manner which is going to just ensure that.
So how will Ayushman Bharat digital mission impact healthcare in India? While you have spoken about that there are basic building blocks it is working on, but in reality, how it will come out for patients, what will entail, for doctors, what will entail?
Yes. So basically, you are trying to ask me how it will be executed now. So again, very fundamental question, very important question. So there will be a health ID of a patient, just like you have an Aadhaar ID. There will be a health ID. The government of India calls it ABA, Ayushman Bharat Health Accounts. So every data, every record, every piece of data generated about that patient has to be tagged to that health ID. This is the most fundamental thing. To make that happen, there will be two other IDs. One is a health practitioner's ID. So a doctor will also have an ID. A nurse will also have an ID. Anybody who's providing services will have an ID. Then there is a health facility registry. So every health facility in this country, operating in this country, will have to get registered around on ABDM platform, and they will have to generate the record and tag it to the patient health ID. So now visualize yourself a situation where you are a patient. You come to me for a primary consultation, and I generate your prescription and I tag it to your health ID. Now you go to the Apollo hospital, maybe Fortis, or maybe anybody, any government hospital you go, and you go for some other procedure, and then you tell him that this is your health ID. So the doctor out there will punch in the health ID in this ABDM system. You will get an OTP because you are the patient and you own the data. You will share the OTP just like a consent manager, and the doctor who is there at that institution will be able to visualize your whole longitudinal health record. So now the need to carry truckload of files just disappears. So now there will be very good summary of your health. So maybe you had an episode of, say, accident some time back, you had a leg injury and you had a fracture, say 10 years back, and that will be recorded out there. So now no need to carry that file, that what happened at that point of time. And the doctor will be able to visualize that. That is one piece. So that is exchange of information on the platform seamlessly between the stakeholders as per your consent. Second thing is ensuring financial transaction of health. So that will be a transaction layer built over this, on top of this ABDM. So now think of it as a situation where you go to a hospital, you are insured. Now what happens is that you have to inform the insurance company that you have fallen ill and now you are being hospitalized. And the hospital has to also inform the insurance company that so and so treatment has been, or it is being given. Now the insurance company validates the information, and then they give you a pre-authorization or an authorization. Once the treatment is completed, you are being discharged. Again, the hospital has to raise a permission from the insurance company that now they want to discharge you and to settle the bills. So this process in itself takes sometimes 6 to 8 hours. So might be you had to get discharged at 6 a.m. in the morning. Now you are being discharged at 6 p.m. in the morning, just because that authorization has not come from the insurance industry. So once this whole ABDM goes live, the basic transactions or the health information sharing happens, then this financial transaction also happens over this as a separate layer. So now the insurance settlements will happen on a real-time basis. Secondly, think of it from as a counter view of the same situation. You want to purchase a health insurance. Now again, just like you have a KYC for a financial kind of identification, you go to bank and they take your documents, they do a Aadhaar scanning and they get all your details. Just like that, tomorrow when you will go for, say, purchasing a health insurance, using the same health ID, the insurance company will be able to understand your health history, understand how well you have managed your health, and maybe you will get more discounts around that. So the system will become more efficient. It will become a win-win situation for all the stakeholders. You will be discharged on time, hospitals will get paid on time, and insurance industry will be able to minimize the frauds. So eventually the whole sector will grow as a ecosystem.
So Ayushman Bharat digital mission is still a new concept, right? and there are hospitals, there are clinics, and then there are individual doctors who are also operating out of there, right? And whatever I have read, it's not yet mandated, it's not mandatory to be part of it. So how do you think all of this is coming together?
So to give you some more context, so when we started with the Aadhaar, so nobody believed in Aadhaar or UPI for that sake. So Aadhaar became mandatory once more than 70 or 80 crores Aadhaar IDs had been generated, right? So once we had crossed a certain benchmark or certain momentum, the government became confident and they made it mandatory. So just to compare with that context, the ABHA IDs, the number has crossed 37 crores. And we are sitting in 2023, mid 2023. Moving forward, by the end of this year, it is expected that this number will double. So once we reach that critical mass where the government becomes confident that enough doctors have been onboarded, enough health facilities have been onboarded, and enough consumers have got that their ABHA ID. So 37 crores ABHA IDs today, more than 2 lakh health facilities, more than 1.5 lakh doctors already part of the ABDM system registered there. And this number growing every day and then crossing a critical mass. I think it is coming together very beautifully, and it's just a matter of time when everybody becomes aware about it and starts participating in it. And to make that process more kind of frictionless, Government of India has come out with a digital health incentive scheme where every stakeholder in theory can get up to a maximum 4 CR per annum. I think which is a big number, and just by participating in it and without doing any extra services, without providing any extra services, every stakeholder who is providing a service to the patient can earn that amount. So I think it's a big kind of provision by the Government of India, and I can foresee it coming very beautifully.
So how can a doctor who doesn't have much information about ABDM at this point of time can go ahead and be part of this as a system? What steps does he has to take, or what things he needs to ensure his clinic should have to be part of this system?
So see, there is no extra kind of effort that is required. Number one, every information is available on the government website. It is www.abdm.gov.in. Each and every information is available there. Number one. Number two, if the clinic or the hospital is registered with the local CMO office or as per the state regulations, then they can just go ahead and adopt any ABDM compliant software. So there are many. So if you're a hospital, you have a ABDM compliant. HMI is by CDEC, the Government of India, and there are private players like Briefcase. And if you're in a clinic, there are ABDM compliant softwares like EkaCare and Bajaj Health, which can help you kind of become ABDM compliant as a software or facility viewpoint. And then they will also help you get onboarded on this ABDM ecosystem. Once that is done, you need to ensure that the patients who are coming to your facility, they take appointment using scan and share function of the ABDM platform. And once they do that, then you just have to ensure that all these data records of the patient, they are to be uploaded on that compliant software. Once you do that, nothing more is required, and government starts paying you incentives, say maybe 1.5 to 2 months after you have reached a critical mass again. And for that, I think for clinics, it is important that you need to have at least 100 patients per day, and beyond that, government pays 20 rupees per patient per record.
Is it per day or per month?
So it is 100 patients per month, and the incentive is 20 rupees per patient per record. So if you have more than one record, the more you earn. So it's like that.
So that has been extremely helpful information, doctor, and thank you for coming here and helping us learn more about your journey in general, and doctors, the kind of pressure they feel, the kind of stress they feel, but still at the end of the day, they go back to their patients, helping them with a happy smile.
Thank you. Thank you.
Thank you very much, Dr.
It was indeed a pleasure with you and conversing in this kind of space. Thank you.